On to our next speaker, and it's a great pleasure for me to introduce Fernando Donnellan. And Fernando, if you can come up and give us your talk on what's happening in Brazil. Fernando,
yeah. Thank you very much. I would like first to thank you, the organizing committee, for the opportunity to talk to you this morning. And I'm going to talk about the transoral robotic surgery in Brazil. So what we have in Brazil, we have 200 million inhabitants. Of these, 150 million patients are treated exclusively at the public health care. The other 50 million patients, they are treated in a private or insurance health care. These are two completely different healthcare systems. Most of the physicians work in both of these environments, like we do in the Federal University of São Paulo and also at a private clinic. And so we have to, this is an important thing to stress, that we don't have yet, and we are going to show us, where do we have the robots and where can we operate these patients on? Because if you are in the public system, okay, you need to have a robot in there in order to achieve those huge 3/4 of the population, and it's not what we have yet. So what do we have in Brazil? We have 13 Da Vinci robots. The majority of them are located in southeast portion of the Brazil, mainly in São Paulo state, Rio de Janeiro, and also in Rio Grande do Sul state. Of these, 10 are in the state of São Paulo, 9 in the city, in the capital city of São Paulo, 1 in the interior, and 2 in the city of Rio de Janeiro, 1 in the city of Porto Alegre. And we have 11 hospitals with these robots in Brazil. In red, we can see the hospitals that are entirely public ones. So here in ICESP in Brazil, Barretos, and the National Institute of Cancer in Rio de Janeiro is where we can find the robot for treating those patients in the public health system. These are the hospitals that already now have a TORS program. The other ones are most urologic and OBG programs. Barretos and ICESP are going to initiate their TORS program, but they are not yet started. They have not yet started. So we have from last year, and when we do all these hospitals together, we have closely more than 100 cases. And here we can see what happens when we introduce this robot in the public system. Here is when INCA initiated his TORS program. So we start like 5 to 6 cases per year to more than 50 cases per year with the INCA experience. Most of our cases are from the oropharyngeal carcinomas, because in the beginning we have a problem because Olympus haven't approved the FK in Brazil. So we have to buy these mouth gags doing IRB approved protocols or doing homemade mouth gags. So for the oropharyngeal carcinoma, we have like 123,000 new cases per year worldwide. In Brazil, we have an incidence of 10.64 per 100 inhabitants. In São Paulo, that's where we came from, we have 7 per 100 in males and 1.2 in females. SCC carcinoma are the majority of the cases, in 95% of them. The primary sites are tonsils, followed by base of tongue and soft palate, with a male to female ratio of 7:1. And also, these are always related to alcohol and tobacco consumption, but now we can see an increase in the HPV-driven squamous cell carcinoma of the oropharynx, also in Brazil, not with a higher incidence like here in the US, but like in an incidence like 30% in Brazil. So we can have the pattern of dissemination of the tumor for all the sites, base of tongue, tonsil, soft palate, and you can always see the tumors in here. Also this bulky base of tongue tumor. And what do we have for treatment for these patients? Now, we can see in this historical series from the National Cancer Database that 1/3 of these patients were treated primarily with surgery, 1/3 with radiation alone, and 1/3 with chemoradiation. The initial stages, they do preserve, and they do have similar results between surgery and radiotherapy. Although the advanced stage, they require more advanced therapies and larger surgeries. For surgical accesses, we can have the pull-through approach, the mandibulotomy or mandibulectomy approach, the pharyngotomy approach, and also the transoral approach. Either the classic one, when you use a mouth gag and the bovie, or the robotic-assisted transoral surgery. For years, the most, we have as an option only that the most radical operation should be done as soon as possible to eradicate the last living cancer cell in the surgical field, as stated Sir William Halsted in the 19th century. But in the beginning of the 21st century, we have this introduced by the group of the University of Pennsylvania, the transoral robotic surgery. First with animals and cadaver models, and they started with feasibility and security protocols and papers. So we can have used this approach for treating the oropharyngeal carcinomas. Nowadays, we are not more talking about if it's feasible or if it's safety, but whether we can achieve with this treatment. So here we can have, you can see a paper from also the UPenn when they analyzed their HPV status in patients submitted to TORS. And what did they found? They no statistically significant difference between HPV positive or negative patients, although in the patients with HPV positive, they could suggest the de-intensification of the adjuvant therapies. Also, we try to look for the quality of life aspects of any surgery that we do. So this is the paper that we made when we stayed at our fellowship on UPenn. That's transoral robotic surgery for oropharyngeal carcinoma and its impacts on quality of life. And what did we see? We see that the quality of life domains present a decrease in 6 months after TORS, but it returned after a year of surgery to the baseline values. Emphasize that we can achieve a good quality of life outcome with this approach. This is a similar study from the group from the University of Alabama. That's Dr. Scott Magnuson that was there at the time. They do achieve the same results with good quality of lives after 1 year of follow-up. But of course, that when you need to have chemoradiation adjuvant therapy, the patient perform worse, so we have a higher rate of PEG dependency. Nowadays, we are also seeing not only quality of life issues, but also studies showing that we can have all good oncological results. That's very important in our specialty. So here from the Mayo Clinic group, this study showed that we can have good functional outcomes in 1 year of follow-up, and also that in HPV positive patients submitted to TORS, you could avoid and decrease the need of adjuvant therapy, maintaining the local regional control and survival outcomes in 3 years of follow-ups. And so we can see in this paper the continuing on the treatment of the oropharyngeal carcinomas. When it starts in the 80s, we have only 2 options like radiation therapy and surgery. And we can start having the transoral laser microsurgery, chemoradiation, IMRT, and TORS in the 21st century. And what we are looking for, what we are seeking here, we are looking for de-intensification of the treatment where the patients could have performed better after the treatment with the good oncological outcomes. And also we have to tailor-made our treatment to our patients' characteristics, such as HPV or molecular characteristics of the tumors. So we can achieve a good treatment, a very efficacious treatment with a less invasiveness. So TORS is here. They present both these characteristics when compared to open surgery or chemoradiation. This is when we did our fellowship at Penn, and would like to thank you very much for your attention. And in these slides here is for our Cariocas friends, that we can also have a good views in São Paulo, not only in Rio de Janeiro. Thank you very much.